Anything not clear? Other than how bad my jokes were. All right, here we go. So here's what we call a second order question. If you can't figure out the diagnosis from the question, you're probably not going to be able to pick the right answer. Juniors now get to pick up their game. So, what is this disease process? Yeah, where's the question? I'm nice to you guys. Not being nice back. All right. What are we going to use to diagnose this? Did I ever talk about CT angiography so far? No. I did talk about colonoscopies. I did talk about double contrast enemas. KUBs are worthless unless you're looking for constipation. But what are you going to use to diagnose this? It's going to be a CT, abdomen, pelvis, with or without contrast? With contrast. Good. Yeah, I got a question in there. It's a pretty easy one, right? But remember, there was 4 other things that could be, right? That all pretty much relate to potentially being hospitalized or being old or being immunocompromised. But this one, obviously, pretty simple, recent antibiotic use. Well, you got your choice of B, C, and D because I didn't talk about Levo or Clenda. That's just good test taking skills, eliminate some stuff and break it down. I did talk about bank, but I only talked about bank and PO, so that's out. So it's going to be metronidazole, only for bowel disease. And do we use it in a second recurrence? No. That's good. Second recurrence, maybe it should just be recurrence. It's like the first annual. Inaugural? Okay, gotcha. And there's some lines are blowing out there, I got you. Got the question in there at a time? Alright. 3 out of 4 isn't bad. Great batting average. So anything over 6 centimeters. Concerning for. We will talk about spontaneous bacterial peritonitis. That's a sad thing. We did talk about periodicilitis, colitis. Lower 9 centimeters, we're past that pseudomembranous colitis, and we are in toxic medical lane. We will talk about acute bronchitis at some point. Alrighty, I will remain up here for a few minutes if your light bulb didn't go off for anybody. Sometimes you do got to pull it. Okay, I'm confused with IBS. Questions? And figure out little mnemonics in your head so you don't make things up. A lot of these look similar in multiple slides. But we're reaching for low-risk patient with mild. And if we think back to Crohn's disease, what was the first thing we were going to reach for? B, budesonide. So if it's more diffuse, then we're going to look at prednisone. If this is mild disease, B is your answer. The key to this is that you identify that it has continuous mucosal inflammation extending directly to the spine tush. Not the entire GI tract. The entire GI tract would be Crohn's, right? There's irritable bowel syndrome, colitis. We talked about that at the end. That would be watery diarrhea if we're going to talk about D. So everybody agrees ulcerative colitis is outstanding. Ooh. Anybody have an idea? I didn't talk about this yet. Let's see who pre-read. Nobody. So what's the answer? If they have any form of inflammatory bowel disease, 8 years. In 8 years, they got to screen again. It's a higher risk of colorectal cancer. All right, I'll let you guys go on break, and we'll come back at 33 slides. Who do you have at next lecture? Home? All right, go back to this again. What did I say? Ulcerative colitis, inflammatory bowel disease. At age 30, how many years for the initial? 8. 38. Good. Oh boy. Remember, it's not a screening test. I only showed one of those. Somebody will do it. I don't know why. I didn't even talk about that. Did you pick the right answer? Not the right answer. CEA, right? I don't care how many 100% happen. So first degree relative at the age of 49. What should we do? He's 10 years younger. First degree relative. That's B. He's called last name. Pronto. Pronto. Are we good? All right. This is where I leave you. You get I don't know if she can show up early or whatever. I'll be up here for a few minutes. I'll definitely make sure that you understand ASTs, ALTs, alk losses. I would definitely read up on that stuff, and I'll give you 2 examples. Any questions right now? I get to lecture you guys tomorrow at 1500 at the best. I'm doing what my seniors do. 6:30, they just close their computers and stare. Very disheartening. Some of you are going, oh man, I know what to do. Okay, I'll play your game. Biliary obstruction. So where does the bilirubin go if it's obstructed and can't go down into the cystic duct, into the gallbladder? AE, gallbladder squeezes, pushes cystic duct into the common bile duct. It's obstructed, so E, right? Because the kidney's got to take over, and it's not getting into stool. Good job. Make sense? Not all rocket science. So what's going to be elevated in obstruction? Am I worried about ALT or AST? Nope. I care about where the outfloss is. I'm simply going to pick the one that has the highest outfloss, which would be A. There's maybe one more question on this whole lecture. It's on the test. Just one more. You'll have to figure out what that is. Okay, I can't chew your food for you, okay, folks? All right, I'll stay around for this. All right, let's see what we got here. Did I ever talk about chronic phase? No. Okay, so beat out. I talked about what starts at its viral replication phase, then it progresses to prodromal phase, then vicaric phase, and then convalescent phase. So which one is this? So I'm not saying anything about jaundice. I'm talking about these are just kind of flu-like symptoms. So in prodromal phase. Good. I didn't talk enough about DNA, so you probably rest assured it's either A, B, or C. But I told you that certain things, we have that A is usually fecal oral routes, B, we get concerned, prisoners, sex, and healthcare workers. C, I talked a little bit more about body piercings and tattoo places. So C is going to be your answer. You're going to have to know these. Right, touch G. So surface antigen is just going to give us an idea that they've probably been exposed, and maybe it's replicating, maybe it's not. The envelope antigen would say, oh yeah, they probably had fulminant disease potentially. So core antigen would be if they were actually exposed to the actual disease. But if they were just exposed with the vaccine and they didn't get it, it's going to be D. Maybe D. Go back and look at your slides. It's 100% correct. I won't give you credit if you pick anything else on your test. Maybe. One more. One test that gives you an idea, but there's one test that is 100% going to give you a confirmation. Who do you remember that was?
Bravo.
It's like bolded and underlined, so I hope we pick Bravo. Thank you. All right, you guys want to take a quick break, and then we'll come back and do the second lecture? The break. Okay, more questions here, and then we'll get you folks moving. Hemochromatosis. How do we treat it? What's the first line for treating this? Well, they're holding on to too much iron, so giving them more iron is out, whether even that's oral or through IV. So we're down to B, C, and D. What is deferoxamine used for? Anybody have any idea of that? That's not going to help out. That's iron overdose if somebody takes it orally, little kids. We need to bleed these people. I imagine back in the day it was done with leeches, but now we do it with full body. They will bring them into clinic, take off a liter or two, and see if that helps them out. Kind of work. Sounds very archaic, but not much else we can do to get these iron sources to drop. I did talk about hepatorenal. I didn't talk about iron deficiency. I did talk about poor occupancy. No way, shape, or form did we talk about Wernicke-Korsakoff syndrome. So, but if they're having asterisks, what I talk about was a big thing with that. E, hepatic encephalopathy, right? All right, good to go. Questions, concerns, I'll be up here. Not too shabby. What are you thinking, folks? I think echo, absolutely. What's the giveaway there? It's going to be the pruritus. Severe pruritus. It's going to give it, and then also running with an autoimmune disease. So E is your correct answer. Now we know that this is from too much copper, right? So we can pretty much eliminate all the things that relate to iron as far as hepcidin, ferritin, and elevated total iron binding capacity. So are we C or are we E? Or C. So remember E, it's actually an increase in urine copper excretion. Good job, Wilson's disease. Wilson! So the key with this is that the radiologic study is showing alternating areas of stenosis dilatation throughout the bile duct system, which is going to put that in the realm of, we talked about intrahepatic and extrahepatic, so we're going to go with D. And go with D. All right, that's all I have for you. Okay. So is it cholelithiasis? No, because they're usually asymptomatic. Is it biliary colic? No, they're coming with pretty severe pain. Could it be a cholelithiasis? Could be. What's concerning though is if it's just cholelithiasis, we shouldn't see a temperature and we shouldn't see the fact that the jaundice and the flare up. So that should put us in the realm of D. Okay, D. We have almost like complete stasis of the biliary tree. That's bad. So, and they're febrile. No, this is after a gallstone lecture. You're not going to know exactly based on the test of what lecture it is. It's just not going to relate. So we're not worried about any hypertension, portal hypertension, or any type of sclerosis of the intrahepatic ducts. He's got gallstone intaction twice, so this is probably one of those. What are you guys thinking? Cystic duct or common bile duct? Cystic duct. Yep. Why? Because we're not seeing the evidence of jaundice. Much better idea. Much better idea. Right. Power on or 5-minute break? Power on. Good. Okay. Kind of like it here. All right. That guy. There's only a couple times that we had that positive Courvoisier sign, so that's basically what that's saying, palpable with non-tender gallbladder, right? But we're concerned that we're having all this pruritus. So, what do you guys think? Everybody in 2 would be? Yeah. I say especially in a 62-year-old. Especially in a 62-year-old. If I give you a 22-year-old, I'm like, I'm probably leaning towards something different. Know your demographics. Know your patient population. Doesn't mean that 22-year-olds have never had pancreatic cancer. It's just it's less likely. Less likely. This isn't too hard, right? We have our LDH above like 300, glucose above 200. Over the age of 55, AST typically above 200. So leukocytosis, what I say. I said to know, you need to know that initial Rancid criteria. I don't worry so much about the 48. I know probably that's something you may need to know for your internal medicine rotation, whatever your inpatient rotation is. Every place is going to be a little bit different for phase 2. Reach out to your classmates that are in phase 2 when that happens. Have an idea of what rotation. Talk to them about what things do I need to know. Talk to them about which doctors are, I don't want to say PA friendly, but more apt to let you do more. More apt to let you do more where you are. And I'd rather have a student I gotta pull by the collar than kick in the ass. So get after it. All right, questions? I'll be here.